There we go. Alrighty, can everyone see that okay?
Yep.
Okay, fantastic. So, hi everyone, I'm Yingtong or Lee. No, I don't have a preference which. I wrote this lecture in a caffeine-fueled delirium last night, so I don't remember what I wrote, so let's find out together. All right, let's go. So here is a reproduction of all the conditions that are on the neuromatrix and the presentations that they've listed that they can come under. And I've just highlighted on this slide here what I think the sort of more important ones are for you to know, and the ones that I'm going to go into a little bit more detail on. Maybe not this one. Okay. So I've grouped this mostly by presentation. It occurred to me that because OSCEs don't count anymore, maybe I shouldn't have done that, but what's done is done. So let's start with headache. So in terms of approach to headache, differentiating different causes, obviously we start with our WWQQAA, bias, etc. And just starting generally with where we want to be differentiating what's really sort of a true headache with something that's more a superficial face or scalp pain, thinking there about something like giant cell arteritis or a temporal giant cell arteritis or trigeminal neuralgia. Then in terms of the different kinds of headaches, the pattern and the onset and so on are really, really critical in differentiating many of the types. So you want to ask about the onset, the duration, how frequently does it happen? Has it happened before? Is there any sort of pattern to it? Is it acute? In that case, we might be very concerned about an intracranial hemorrhage, or is it chronic? If it's chronic, then probably it's something that's less immediately life-threatening if it's been going on for a while. Was there a precipitating event? Remembering always to ask about head trauma, or was there some sort of prodrome, thinking about some sort of migraine or so on. Aggravators and alleviators, some things to think about with your differentials. Is there any light sensitivity, noise sensitivity, maybe indicating meningitis and migraine or something? Is it worse in the morning? That's a sign of raised intracranial pressure, and there are a number of causes of that. And perhaps stress or alcohol intake, maybe tension, headache. Then in terms of your systems review and associated symptoms, you're probably reasonably familiar with this just from general neurosystems review from preclin, but visual change, visual loss, and associated with that pain on chewing, and any other sort of joint pain that can be associated with giant cell arteritis, which might be go hand in hand with polymyalgia rheumatica. Any systemic symptoms that might indicate any sort of infection or any sort of weight loss to indicate a tumor, and again, systemic things with PMR. Any neck stiffness, of course, and any nausea and vomiting also with raised intracranial pressure. So in terms of the sort of key differentials for a headache, the most common sort of things that you think about are a migraine or a non-migraine primary headache, which there's a bracket there, I'm using to mean a tension or cluster headache. The red flags that you definitely don't want to miss are things like meningitis or encephalitis, an intracranial hemorrhage, or a brain tumor. And then the pitfalls, things which aren't so much neuro or classically headachy type things, trigeminal neuralgia, giant cell arteritis, and idiopathic intracranial hypertension. So I'll go through all these individually. Migraine, that's an R1 condition. So the history of a migraine is going to be a severe unilateral throbbing or pulsating kind of headache lasting anywhere between 4 and 72 hours. In Monash land, classically associated with photophobia, but can also be associated with sensitivity to sound or smell. Most people with a migraine will have some sort of prodrome, mood changes, constipation, stiffness, and there may or may not be an aura, which is often visual or sensoromotor. Sorry, I think I referred to aura earlier when I was meant to refer to prodrome on the previous slide. Usually migraine affecting more of the younger people, female more so than male, and associated with the family history. And triggers can be, stress, sleep deprivation, drugs, etc. They'll probably give that to you if you ask. Hormonal changes, caffeine, etc. And it's really just a clinical diagnosis. Management of migraine, you should be pretty comfortable with, as it's an R1 condition. Starting off with non-pharmacological management, keep a headache diary, just try and identify the triggers, and then of course try to avoid the triggers, just general good lifestyle things about good sleep, stress management, and so on. In terms of the setting of an acute migraine, we can start with simple analgesia like paracetamol and high-dose NSAIDs. If that's insufficient, then we can give a triptan or an ergot. And then symptomatically, we can use an antiemetic. The lovely Monash one is prochlorperazine or Stemetil is the trade name of that. If you have more than 2 migraines a month, then you can go onto pharmacological prophylaxis, remembering that triptans are just to arrest the migraine, not so much for prevention. And the main agent is beta blockers, for example, propranolol, but there are also a number of other agents that can be used, which I've listed on the slide. Of course, beware of the risk of stroke when using the combined oral contraceptive pill in migraine with aura. Consider other contraceptives like the progestin-only pill or long-acting reversible contraception. Moving then on to the non-migraine primary headaches, tension headache and cluster headache. Tension headache, think back to the previous meme slide, that's a dull frontal band-like sensation around the head. Triggers for that can be stress, alcohol, dehydration, can affect any sort of age. And then a cluster headache, which is again, like a migraine, unilateral excruciating pain, but a more predominant feature may be potentially retroorbital pain. Can last minutes, hours, and the episodes sort of occur in clusters, hence the name. Usually young people. So it looks similar in a migraine in a number of ways, but the retroorbital pain and in particular cluster headache, you would expect association with rhinorrhea or lacrimation unilaterally on the affected side, which you wouldn't so much see with a migraine. Probably don't need to know too much else about these headaches, but I think it is important to have a good grasp of the differential. It's a very easy EMQ that they could put up with. They just give you a whole bunch of different headaches. Okay, bacterial meningitis is obviously an infection, inflammation of the lining of the brain. Most meningitis is viral, benign, and self-limiting, but if it's got a bacterial etiology, then that's a medical emergency. So in terms of the history, you would expect a history of meningism, headache, neck stiffness, and photophobia. It might also be Brudinski's or Koenig's sign. If they're very unwell, you may have systemic features of malaise or sepsis. There may or may not be focal neurological signs, and there may or may not be signs of a preceding illness, such as an URTI. The classic triad of bacterial meningitis is fever, neck stiffness, and altered mental state. But that only happens in about 40% of cases. So the etiology, don't worry about the etiology in the kids, but you should remember the etiology in older children and adults is strep pneumoniae, Neisseria meningitidis, and Listeria monocytogenes if they're over the age of 50. Don't be like me and get to the OSCE and just blabber and make up something about group B strep, which is not the correct answer in adults. And of course, MRSA in people who inject drugs. In addition to that, if there is a non-blanching petechial or purpuric rash, that's a real buzzword, that is pathognomonic of meningococcal sepsis or sepsis or bacterial meningitis due to Neisseria meningitidis. So that's important to know in terms of the management. So in terms of investigations, as before, because this is a medical emergency, you should start the antibiotics before any further investigations. General staff, a bit of a sepsis screen, try and culture and PCR some things. You may do a CT brain to look for raised intracranial pressure. And then if intracranial pressure is not suspected, then you can do a lumbar puncture again for MCS PCR and to look for general lumbar puncture things. In terms of what the lumbar puncture findings are, pretty straightforward. If it's bacterial, you get neutrophils. If it's viral, you get lymphocytes, and then the proteins and glucose change accordingly. In terms of the management of bacterial meningitis, doctors ABCD always. It's very easy to get into the OSCE and just say straight away, I'll give them antibiotics. But reading the stem, usually it says you are a medical student or you are the intern. And you have to say what you would do with the intern, which is I'm going to admit them, I'm going to call neurology, I'm going to insert cannulas, make sure they're stable, etc., etc. Easy marks. Activate the sepsis 6 protocol, give fluid resuscitation, and this is important things to remember. Empirical antibiotics. So according to ETG, the empirical antibiotics for bacterial meningitis are ceftriaxone and dexamethasone. Remember that cephalosporins, like ceftriaxone, are inactive against Listeria monocytogenes. So if you suspect that because they're over 50 or immunocompromised, then add benzylpenicillin to cover that. However, in Monash land, they really like the non-blanching petechial or purpuric rash. So if you have clear signs of Neisseria meningitidis sepsis, the answer in Monash land will be benzylpenicillin alone with no dexamethasone. You should cease dexamethasone if N meningitis is confirmed according to ETG because there's no evidence that it helps. Keep in isolation for ICU, etc. Next condition, viral encephalitis, which is an inflammation of the brain parenchyma itself in addition to meninges. So the signs, symptoms are very, very similar, but the addition of focal neurological signs will suggest to you that perhaps encephalitis is more likely. So that's things like seizures, altered GCS, hemiparesis, ataxia, aphasia, behavioral change, long-term memory, behavioral changes, and so on. The viral etiology can be, whatever virus you like. Encephalitis can also be caused by other causes as well. Next year, you'll probably hear that autoimmune encephalitis can be a sort of mimic of a number of psychiatric conditions. So the investigations, again, similar, because it's similar, it's just as per meningitis, but you would also want to look more closely for viruses and consider EEG. The management of viral encephalitis is usually supportive. Our antiviral drugs don't work that well, but in order to cover HSV, you may give them acyclovir, and you may also just give them ceftriaxone and dexamethasone empirically anyway, just to cover bacterial meningitis and bacterial causes. Okay, moving now to intracranial hemorrhages. So starting off with the epidural hematoma. So this is, remember thinking back to sort of preclin, this is a bleed between the periosteum and the dura mater. So sort of that innermost layer just next to where the bone is. Again, preclin knowledge, remembering that this is associated with a pterion fracture and rupture of the middle meningeal artery, which runs close by there. So the history of epidural hematoma, you would of course expect that there very much should be some kind of head injury, blow to the temple, probably reasonably severe, getting hit with a bat or something. Classically, there is a brief loss of consciousness and then a lucid period where they appear to be fine for a period of time, and then the headache strikes and they rapidly deteriorate. In terms of the investigations for any intracranial hemorrhage, it's a non-contrast CT brain generally. And for an epidural hematoma, you will see an elliptical shaped biconvex hematoma, or a red lemon is the mnemonic, where red means arterial, which, a bit silly, but was better than my mnemonic. Management of epidural hematoma, again, always doctors A, B, C, D. If they're bleeding, you want to stop anticoagulants, resuscitation, again, all part of your doctor's A, B, C, D stuff, plus or minus seizure prophylaxis. And because of the nature of the bleed, you're going to need to call in Charlie Teo and get a decompressive craniectomy or craniotomy. The next intracranial hemorrhage is a subdural hematoma. So that's sort of the next level down between the dura and arachnoid mater. Again, real preclin revision at the moment. That's generally a tear in the bridging veins. So it's a venous bleed. It can also be due to trauma like a fall with head strike. It's also more commonly seen in older people, especially on anticoagulants where, the veins and stuff aren't working so good, or alcoholics, again, where there's a bit of atrophy and it's not holding up together quite so well. So the history, again, headache, gradually worsening confusion and level of consciousness, probably looking more at the risk factors to guide you there. And because of the nature of the bleed, it can be an acute headache or it can be a subacute or chronic kind of bleed. And I'll show you one in a minute. Again, the investigation test for any intracranial hemorrhage is a non-contrast CT brain. This time you get a blue banana, blue for veins, or if you want to sound a little bit more sophisticated, a crescent-shaped hematoma. The management depends on whether it's acute or chronic, and whether it's large or small. If it's just a very small one, if it's been going on, you may just use conservative management and it should resolve with time. If it's large, you may need drainage with clot evacuation. And if it's a really emergency situation and they've really decompensated, then you may again need to call in Charlie Teo and manage as per an epidural hematoma. So here I've got an image non-contrast CT of some subdural hematomas. Here you can see that blue banana shape. So the one on the left you can see is hyperdense on CT, it's white colored. Recently clotted blood is white on CT, so this is an acute subdural hematoma. Contrast with that one on the right, where there's this blue banana shape, but it's not white, it's hypodense, or it can even be a very similar density to the brain, making it hard to see. That's indicating that this is an old clot, hence a subacute or chronic subdural hematoma. You can get one on top of the other as well, in which case you get both appearances. And if you're looking for more clues, you can see that there's a shifting here due to the mass effect of the lesion. You can see the ventricles aren't appearing symmetrically. Okay, and the final big bad intracranial hemorrhage is a subarachnoid hemorrhage. So this is bleeding into the subarachnoid space, generally due to a ruptured berry aneurysm, which is associated with polycystic kidney disease. Other associations with subarachnoids are hypertension, arteriovenous malformation, substance abuse, and so on. So this one, again, history is key. You will get a sudden onset, so-called thunderclap headache. If the patient tells you, oh, it's the worst pain I've ever felt, and it's not a kidney stone, think subarachnoid hemorrhage if it's a headache. They may have a sentinel bleed, which is a sort of similar headache weeks earlier due to a sort of similar leaking of the aneurysm. If you've caught it at that time, then it's very important that they get a CT brain to look at what's going on. And because you've got stuff going into the subarachnoid space and irritating the meninges, you can get some meningism as well. And obviously, because of the nature of the bleed, it's arterial, they can also have very rapid deterioration. Again, say it with me, the investigation for an intracranial hemorrhage is a non-contrast CT brain generally, and you'll see a very classic spider-like appearance, spider hemorrhage. Or alternatively, if you just get it in that sentinel bleed stage or before the onset of an actual hemorrhage, you may be able to see the berry aneurysm or AVM. The management of this one, again, is a surgical emergency. So always, doctors A, B, C, D, resuscitation, seizure prophylaxis, and then some general measures. But ultimately, of course, they'll need surgery, which is generally endovascular coiling or clipping to stop the bleeding. So here you can see the spider hemorrhage appearance. I think it looks like a starfish, but you know, each their own. So next condition, brain tumor. So in terms of the history of what you'll see there, because the brain tumor will result in increased intracranial pressure, you'll get signs associated with that. So that'd be a headache that's worse in the morning when everything's sort of been, pressure's sort of been building and pooling. They may or may not have additional nausea and vomiting, and they may or may not have focal neurological signs or behavioral change associated with the tumor. Of course, because it is a cancer, they may have weight loss, and if you're thinking metastases, they may have a past history of cancer. Most brain tumors are secondary, i.e. metastases, but primary tumors are more likely in children. Adult primaries are mostly supratentorial, children mostly infratentorial, and primaries rarely metastasize. So the main danger of a primary brain tumor is the mass effect. Pathologically, multiple lesions, more likely to metastases, etc., etc. In terms of the pathology, starting with the primary brain tumors, you have the astrocytoma. A grade 4 astrocytoma is a glioblastoma. That's a very poor prognosis there. If they give you something to look at, it'll probably be one of these. It's a very aggressive tumor. It may have a necrotic appearance, which you can see different densities in the tumor here, and it may cross the midline, which is characteristic of a glioblastoma as opposed to an earlier stage tumor, giving it the sort of characteristic butterfly tumor appearance. Next brain tumor is a meningioma, arises from the arachnoid mitre on the meninges. This one, by contrast, will have a well-defined border on a homogeneous appearance with a contrast uptake, slow growing, often benign in and of itself. Acoustic neuroma, you'll probably learn more about in general practice next year. It's a benign tumor of the Schwann cells of the vestibular nerve. It presents with unilateral hearing loss, tinnitus, and disequilibrium, just feeling a little bit off kilter in terms of your balance. Yeah, it can be life-threatening if it's not diagnosed, though. In terms of pituitary adenoma, hopefully you will learn more about this in the endocrinology lecture. I've got a typo. Pituitary adenoma may be non-functioning or functioning if it doesn't secrete, or if it secretes hormones. Most common is a prolactinoma, so that of course gives you things that prolactin does, like gynecomastia and galactorrhea. Can also be ACTH secreting, growth hormone secreting, etc. In addition to the hormone effects of a functioning pituitary adenoma, you may of course have mass effect symptoms. Again, classically a bitemporal hemianopia. You may also have ophthalmoplegia, headache. If it's very severe, loss of sensation on the face or stroke. And if it's large enough, it may cause hyperpituitarism by sort of outgrowing the rest of the actual normal functioning pituitary. Next, craniopharyngioma, just a differential diagnosis for hyperpituitarism. Very similar, but it can't secrete hormones. And moving on then to the secondary metastatic tumors, very common, 50% of all brain tumors. People who have cancer may reasonably frequently have brain metastases. These are often at the junction of grey white matter. As I said earlier, they're more likely to have multiple metastases, multiple lesions on imaging, and those are of course associated with a poorer prognosis if there's more of them, or if they're more invasive. In terms of the examination for any kind of brain tumor, we may see papillary edema on fundoscopy due to the raised intracranial pressure. In terms of investigations, obviously CT, MRI brain to look at the lesion, take a biopsy to find out what it is, and if it is metastatic, then we need to search for a primary based on history and based on the results. In terms of management, general cancer things, surgery, radiotherapy, chemotherapy, palliation, and if there's raised intracranial pressure, we can give symptomatic relief through dexamethasone. Excuse me. The next one that I've put is trigeminal neuralgia. I couldn't see that this was on the matrix, but I've just put it in as a sort of differential. Unilateral facial pain, an electricity-like feeling because it's a neuropathic pain. And similarly, you may have allodynia, which is where normally innocuous stimuli begin to feel painful. Not to be confused with post-herpetic neuralgia, which is a different condition that's associated with shingles. Giant cell arteritis, I have had a check, and you should be hearing about this in rheumatology later today, but just generally, very briefly, you would expect that this is less of a headache and more of actual superficial temple and scalp pain. There may be jaw claudication or pain with chewing, and there may be transient vision loss, which is a red flag because that can become permanent. It's associated with polymyalgia rheumatica, so you may have shoulder or hip girdle pain or stiffness, malaise and general systemic unwellness. The investigations are temporal artery biopsy, among other things. Management is prednisolone. Idiopathic intracranial hypertension is another cause of a headache. Probably don't need to know too much about this, other than that it's more common in obese women of childbearing age. Because it's intracranial hypertension, you get those features of raised ICP, you may have diplopia, ophthalmoplegia. You may be able to identify that, well, firstly, looking on CT, MRI brain, and then if you do a lumbar puncture, you may actually be able to record that there is actually a high opening pressure directly. Okay, that's all for headache. We're getting through it. The next is is approach to confusion. Now, realistically speaking, there's really only two conditions that you're probably going to be thinking about here. Delirium or dementia, otherwise known more nicely as major neurocognitive disorder. Dementia is very much a topic for psychiatry next year, so it's probably not going to be the answer this year. So I'm more going to focus on delirium, but just to give you an idea, delirium is characterized by a disturbance in cognition, but also particularly in attention and awareness. It's associated with a very acute onset and a fluctuating course that goes up and down. And in order to call it delirium, you have to find out on some sort of organic cause. So acute and fluctuating is delirium, whereas a chronic and progressive, more just cognitive decline that's impairing the person's independence in their activities of daily living, that's more a dementia. So I'll speak about that in a little bit more detail. In terms of establishing history of this, collateral is key. You need to be asking witnesses, family members, friends about this, because Obviously, the person themselves is not necessarily going to be able to give you a particularly useful history. Again, the pattern of the condition is going to be very important to differentiate the different causes. So you need to ask about onset. If it's sudden, acute onset, you're thinking delirium. If it's been an insidious onset, it's just sort of been happening for a while now, maybe it's more of a dementia. The pattern of decline, has it been, I'll speak about this later, but a pattern of decline has been a very gradual onset, a very gradual progression, more associated with Alzheimer's dementia. Has it been a very stepwise progression? They've got worse suddenly, step by step. Maybe it's vascular dementia. And if it's a fluctuating course, it gets better and worse. You're thinking delirium if it's acute, or dementia with Lewy bodies if it's more of a dementia picture. Precipitants, very important when thinking about delirium in particular, especially asking about any signs or symptoms of infections and just doing a general systems review for every system to work out if there's possibly an infective etiology. In terms of the quote unquote where the cognitive impairment is, there are sort of 6 main domains here. Frontal executive function, which is responsible for high-level decision-making and personality, complex attention, memory problems, perceptual motor, language, and social cognition. And then in terms of associated symptoms, you may like to ask about things like orientation to time, place, and person, any changes to sleep, or any hallucinations. The real key thing about approach to confusion in third year is that you need to rule out delirium before considering dementia. Don't be like me in the practice OSCE, forget that the word delirium exists and diagnose the patient with acute decompensated dementia. No, the word you're looking for is delirium. Okay. Cause of delirium, I put together a little bit of a diagram here. Basically, anything going wrong could cause delirium, so that's not very helpful. So you really have to have a systemic approach to sort of what are the possible things that could have happened here. So things can be caused by, the main ones to think about are infections, particularly urinary tract infections, because I mean, it's a little bit difficult to pick up if you don't think about it and test for it. And pain. So any cause of pain can cause delirium. So it may, including, for example, constipation. There can also be, organ failure, endocrine, metabolic things, intracranial events. And in a person who appears to be otherwise well and you haven't sort of found anything, consider drug intoxication or drug withdrawal, particularly alcohol withdrawal. You'll probably talk a little bit more about this next year if you haven't already as well. But think about Wernicke-Korsakoff syndrome, which is, if you think back to preclinical those metabolism lectures when everyone was talking about thiamine, pyrophosphate, and alcohol metabolism, this is why. Acutely, thiamine deficiency in alcohol use can give you Wernicke syndrome, which is a very acute encephalopathy, and more chronically, it can cause irreversible brain damage, which is known as Korsakoff syndrome. That's characterized by more sort of long-term issues with memory, confabulation. They just sort of make things up. So beware the post-op used car salesman. This is the used car salesman or the politician who's just been admitted to hospital for some sort of routine operation. Operation went fine, they were doing fine, and then suddenly they became delirious. Think about alcohol withdrawal. Can also cause seizures as well, alcohol withdrawal. So in terms of delirium, the assessment for that, you should perform a cognitive assessment with the MMSE or the Montreal Cognitive Assessment. And the MMSE of less than 25 out of, or less than or equal to 25 out of 30 implies impairment. As before, do a head-to-toe exam of every system, listen to their chest, feel their abdomen, etc., etc. Vital signs, check if they have temperature, maybe they have an infection. And the investigations are going to be guided by if you have any history or exam findings. But if not, I guess you're sort of just going to do everything. Most importantly, do a dipstick of their urine. MCS, make sure they don't have a urinary tract infection, because if you don't look, you're not going to find it. And if you miss that they have UTI and they get urosepsis, it's going to be very, very bad for everyone involved. And then just investigations to anything else that could possibly go wrong that could cause delirium. Because they're not going to be able to give you a very good history because you can't necessarily see what's going on, there's a low threshold as well to order imaging like chest x-ray or CT MRI brain. And you can also consider puncture, EEG, other tests. So the management of delirium, really obviously, you have to treat the underlying cause because by definition there must be one. And then really close observation from staff, close observation of vital signs, maintaining adequate nutrition and hydration, and then setting up the environment in a way that's going to sort of help them with their disorientation. So maintaining their orientation with signs, clocks, calendars, etc. You know, big sign, you're on the hospital, today's this date, blah, 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 is what's going on. Minimal stimuli, and encouraging visits from familiar faces, family, and so on, ensuring they have good sleep. Medication management is not so important, but we should probably cease their non-essential medications, give them pain relief if required. And if they are, if there is an acute behavioural disturbance, then you can use antipsychotics like haloperidol for acute sedation. Avoid benzodiazepines in patients with delirium because that can precipitate delirium. But if they have alcohol withdrawal, so remember back used car salesman, alcohol withdrawal, for example, you can give diazepam for seizure prophylaxis in that case. I'm not going to talk a lot about dementia or major neurocognitive disorder because you'll learn more about it next year. Really, all you need to know, the most common, 2/3 are Alzheimer's disease. This starts with an impaired memory, gradually gets worse until they have a global decline in function. And there can also be other behavioral and psychological manifestations. So don't get confused if it's more than just memory. Vascular dementia is basically associated with strokes. You get a stroke and that causes dementia. So of course, if you get more strokes, you get suddenly worse. Another stroke, suddenly worse. So that's a stepwise decline. Frontotemporal dementia has a bit of an earlier onset. That's a sort of early onset dementia kind of picture. They have a family history of that. And that's remembering that the frontal lobe is associated with executive function and personality. That's the things that are going to change in frontotemporal dementia. And then you have dementia with Lewy bodies, which is a triad of fluctuating mental state, spontaneous Parkinsonism, and recurrent visual hallucinations. So just remember the triad for now. Okay, that's all for the sort of 2 confusion conditions. Now is weakness. A lot of this is going to be a little bit of revision of pre-clin stuff, but his palms are sweaty, knees weak, arms are heavy. So in terms of taking a history of weakness, again, just general history taking, you're going to really want to know, is it an acute thing, maybe a stroke, or is it something that's a bit more chronic? Yeah, I've just had this tingling in my fingers. It's been going on for weeks now. Has it been getting better or worse? Is it episodic, or is it worse at the end of the day? Aggravators and alleviators, does it get better with rest? Is it worse with rest? Is it worse with heat? Oh dear, I've got another typo. In terms of associated symptoms, have they had a recent illness? Might tip your thoughts towards Guillain-Barré syndrome. Are there any systemic symptoms? Maybe the weight loss suggesting a tumor. Is there any pain, or is it just weakness? And then a sort of general neurosystems review. You want to know if they have any other deficits. If they have difficulty breathing, important to ask, that's a real red flag sign, a very bad sign. Things like myasthenia gravis or motor neuron disease. And the other things that are sort of associated with neuro systems review questions. Just thinking as well about proximal muscle weakness, maybe ask some questions about thyroid function. Selected differentials, common ones: stroke, carpal tunnel syndrome, Parkinson's disease. Red flag conditions that you don't want to miss: brain tumor, multiple sclerosis, myasthenia gravis, motor neuron disease. And pitfalls are non-neurological conditions that can cause weakness, autoimmune conditions like polymyalgia rheumatica, which we mentioned earlier, and things like hyperthyroidism. So I'll go through these and a few others in some more detail now. Stroke, obviously, if someone says that they've suddenly become weak, important one to think of. The etiology: most strokes are ischemic. That's where there is insufficient blood flow. So these can either be thrombotic, when there's a primary clot that forms at the location of the blood vessel in the brain. It can be embolic, where this is where, you have a clot, for example, in the carotid artery, you've got plaque, a little bit of that flicks off and lodges in the brain, or maybe you've got AFib and a thrombus is formed in there and a little bit flicks off and goes to the brain. Or it can be due to just hypoperfusion, where not enough blood is getting there. Alternatively, important to keep in mind, it can be a hemorrhagic stroke if there's bleeding in the brain. That's quite problematic. So don't get confused between a stroke and a transient ischemic attack. The transient one is where the symptoms are reversible. There was a stroke, but then it's sort of self-resolved and dissolved itself. Amaurosis fugax is painless transient loss of vision in one or both eyes. So the history of the stroke, you want to make sure, do they have any CVD risk factors for a stroke? And it will be sudden onset, usually painless, because where's the pain going to come from? And the symptoms will vary by the location of the infarct. And obviously the classic one that members of the community are educated in is fast. Face drooping, arm weakness, speech slurred, must act fast. Okay, be warned, there is going to be some anatomy coming up, so future physicians look away now. You do need to be quite familiar with the, I guess, the syndromes that are associated with each of the vascular territories of the strokes. So in terms of an ACA stroke, that presents with contralateral leg weakness and sensory loss, and some possible cognitive deficits as well. So this was a little bit difficult for me to remember, but I think if you go Google Images, it's difficult for me to explain, but if you look at where that vascular territory of the ACA goes in relation to where all the parts of the brain are, if you look at it from multiple angles and get an idea of three-dimensionally of where everything goes, I think it's a little bit easier to remember. So in this slice here of the homunculus, which is roughly in here, you can see that the ACA obviously does the anterior parts of the brain, but it also sort of wraps around and does the middle bits, which is where your legs are in the homunculus. That's why you get leg things, maybe, if that helps you remember. MCA stroke, well, it's the opposite to the legs. You get contralateral arm, face weakness, you get the whole range of symptoms, homonymous hemianopia or quadrant synopia. If it's on the dominant side, which is usually the left MCA because most people are right-handed, then you may get a Broca's aphasia or a Wernicke's aphasia. If it's on the non-dominant side, then you may have contralateral hemi-neglect. So they just sort of ignore everything that's going on that side. And there may be other things as well that are put on the slide. PCA, oh dear, what was that? PCA stroke is the one that gives you weird visual stuff. So if it's occipital stroke, then you will get a contralateral hemianopia or quadrant synopia, similar to MCA, but in the PCA setting, it will be macular sparing because the PCA areas actually receive information from both sides receive information from macula. Of course, if it's bilateral, then you'll get cortical blindness. If it's in the midbrain, you may have cranial nerve 3-4 palsy, hemiparesis. If you get thalamus, you get sensory loss, weird things. The most common presentation of a PCA stroke would be the occipital symptoms, so important to remember. Next one, lacuna infarct. What the hell is a lacuna? This is an infarction of the deep white matter. So there are a whole range of different lacuna infarct syndromes, which please don't think about them. Just remember the important two. If there is a pure contralateral motor loss or a pure contralateral sensory loss, so there is only motor deficits or there is only sensory deficits, then the answer is lacuna infarct. That's all you need to know. Okay, the next one, going back to preclin, pica stroke. To be totally honest with you, I did not understand this in preclin, and I did not understand this in third year, and I did not understand this until last night when I was doing study with the second year. We found this really great video on the rule of fours. It does actually a very good job of explaining brainstem stuff, brainstem stroke, so I do recommend that. So this was me before, but hopefully with that video, that won't be you. So in terms of a pica stroke, that gives you lateral medullary syndrome. So just remember the structures that are in the lateral medulla, and those are the symptoms that you're going to get. So I've put them on the screen for you. You can think through that or apply my approach where if you've got weird contralateral and ipsilateral symptoms in a stroke, you put weird brainstem shit. Okay, and I've just got a picture here of the comparing the visual field defects. So you can see MCA stroke, you may have contralateral homonymous hemianopia or a quadrant synopia. And if you have a PCA stroke, you get the same thing, but with macular sparing. And of course, from earlier, if you have pituitary adenoma, for example, that causes a bitemporal hemianopia. In terms of, okay, that's the end of the anatomy. You can start paying, physicians start paying attention now. The stroke. Of course, you want to do a comprehensive neuro exam to determine the pattern of the stroke. In terms of investigations, immediate non-contrast CT brain. Look for possible etiology. Maybe they've got undiagnosed diabetes, Do they have AFib? Do they have carotid stenosis? And then if you're considering thrombolysis, then you'll need a group and hold just in case, and to look at the clotting profile as well. So the management of an ischemic stroke, once you've ruled out a hemorrhage, because obviously you don't want to give them clot busters if they're bleeding. If it's within 4.5 hours of onset, you can give thrombolysis with a tissue plasminogen activator like alteplase, control their BP and give them aspirin. If it's between 4.5 and 6 hours, you can do endovascular thrombectomy. So they need to go to a tertiary center for that. Monitoring, of course, withhold antihypertensive unless it's crazy high, supplemental oxygen, obviously, if they're hypoxic, watch BSLs, and obviously just thinking about OTPT rehab early. And again, oh dear, I fell into the mistake that I said you shouldn't do. Remember, always start with doctors A, B, C, D, because again, you're going to be the intern. That should be the first thing you do. Yes, I'm going to admit them. I'm going to have a stroke call, etc., etc. Okay, carpal tunnel syndrome, haha, funny joke. Remember, review your pre-clin. You get lateral palm paresthesia or numbness, thumb weakness, etc. If they're overweight, pregnant, whatever. Management, you can do conservative or surgical. Hopefully remember that ICL. Parkinson's disease, chronic condition. The key characteristic will be a shuffling gait, a Parkinsonian gait. They may try to trick you by describing that they have difficulty turning or something. Don't get confused. They're still describing the same kind of bradykinesia and shuffling gait. The mnemonic for Parkinson's disease is TRAP. So you have a coarse pill rolling, resting tremor. You may have rigidity, akinesia or bradykinesia, and postural instability. Also the masked faces of Parkinson's disease. Eventually, because it's a progressive condition, you get more cognitive decline, dementia, decreased speech, libido, depression, and autonomic dysfunction and things. So Parkinson's disease is idiopathic Parkinsonism. So in order to get that diagnosis, you need to exclude other causes of Parkinsonism. I've listed a number, but I've mentioned dementia with Lewy bodies, which can give you spontaneous Parkinsonism. You have Wilson's disease, which may give you Parkinsonism in the young, and dopamine antagonists like metoclopramide or antipsychotics, which have that effect, can give you drug-induced Parkinsonism. So exclude those. And then give them a trial of therapy. If they improve, the diagnosis is settled. So the management, if they don't have enough dopamine, we give them dopamine replacement, levodopa plus carbidopa. The most common side effect is nausea. So don't use metoclopramide because that dopamine antagonist crosses the blood-brain barrier. And if they don't have enough dopamine in the brain, then stopping the dopamine is going to be even worse. So give them domperidone, which is similar but doesn't cross the blood-brain barrier. You can give other agents, talk about the psychiatric issues and some other wacky further line things as well. Probably less important to know. Okay, multiple sclerosis is an autoimmune demyelinating condition of the CNS. So because it's an autoimmune disease, it's more common in young women. You get features of demyelinating disease, so weakness, spasticity, gait changes, vertigo, and incontinence, and it's usually episodic. So they might have a first episode and then it goes away, and we don't diagnose them with multiple sclerosis yet. If they get it again, maybe it's multiple sclerosis. Can be worse on hot days and can be associated with optic neuritis. So that gives you pain in the eye as well as change in vision, important pain in the eye. There are 4 patterns from most to least common. The most common is the relapsing remitting form of multiple sclerosis. You get an episode, gets better, get an episode, gets better, but it can be progressive, it can be secondarily or primarily progressive, etc. And it can go from one to the other. So in terms of investigations, MRI brain, look for, I guess, just remember the pathology buzzwords, hyperintense lesions on T2, which are the demyelinating plaques, and Dawson's fingers. On a lumbar puncture, again, buzzwords, oligoclonal bands, and an increased IgG concentration. Multiple sclerosis can have effects on lung function, so they should get a lung function test as well. That's not just for respiratory conditions, but anything that can affect the lungs. In terms of management, acutely IV methylprednisolone, long-term immunotherapy, because of course it's autoimmune disease, manage their lifestyle, and you give things for symptom relief. But of course they're going to need something to treat the underlying condition as well. And if it's an OSCE, say, here's a pamphlet from MS Australia. Myasthenia gravis, Oh dear, we're getting confusing. This is another autoimmune condition of the nervous system. This time it affects the nicotinic acetylcholine receptors at the neuromuscular junction in the skeletal muscles. So this is a peripheral condition. Again, because it's an autoimmune condition, it's more common in young women or older men. Again, you get the weakness and stuff, so it sort of seems a bit similar. The things to look out for is that in myasthenia gravis, it may be worse at the end of the day or with activity, and you may have blurred vision from drooping eyelids. So remember, multiple sclerosis, painful eye and visual changes. Myasthenia gravis, blurred vision from drooping eyelids. Because of the autoimmune etiology, most will develop a thymoma. And in terms of the investigations, it's those myasthenia gravis antibodies. You can look for the thymoma and see if there is one. You can do this edrophonium test, which is essentially a trial of therapy. You give them edrophonium, which is an anticholinesterase. If they get better, it's myasthenia gravis. And again, because myasthenia gravis can impact lung function, give them lung function tests. The management is a thymectomy, even if they don't have a thymoma, and immunosuppressants, IVIG, etc., to treat the autoimmune component. And then once you've done the immune therapy, you can give them symptom relief with the anticholinesterases. Okay, motor neuron disease, who knows how to spell that one? Usually when people say motor neuron disease, they mean ALS, so that's the one I'm going to talk about. There are a number of other types of motor neuron disease, and you'll come to learn more about spinal muscular atrophy next year in pediatrics, but for now, just forget about it, just think about ALS. Buzzword for MND is fasciculations. Again, muscle weakness, progressively worsening, and important red flag symptom, they may have difficulty breathing or difficulty swallowing. So important to elicit that symptom. Investigations, EMG to look for that. You can exclude other causes of weakness. And again, because very importantly, difficulty breathing, give them lung function tests. The management of motor neuron disease is mostly palliative. There's a little bit around the sides, but it's an R3 condition, so don't worry too much about that. Unfortunately, it is generally fatal within about 3 years due to that respiratory failure. Okay, myopathy, don't worry too much about this. This is just when the muscle don't work so good, not because of a nerve issue. So you have symmetrical motor weakness, but with normal sensation. So we know that thyroid disease can give you proximal muscle weakness. Next year, you'll learn more about the hereditary muscular dystrophies. Don't worry about them now. And Mac later is going to talk a little bit about the myositis and things, but again, don't worry too much about those. Okay, spine disease, hopefully not too complicated. Spinal stem, I won't labor the point, but spinal stenosis, just remember that's a gradual narrowing of the vertebral canal, so a gradual onset, whereas disc prolapse is an acute onset, gradual versus acute. And if you really, really think back to pre-clin, you might remember this diagram with, which nerve is affected with which disc prolapse, blah, blah. Management is mostly conservative. You can give painkillers, steroid injections. If it's really bad, you can do surgery, but I'll let you read through all that in your own time. One thing to think of with spine disease is cauda equina syndrome. So this is where they get compression of the cauda equina at the bottom end of the spinal cord. It might be due to a tumor, trauma, prolapse, etc. So this will give you the sciatica type pain previously, but also give you double incontinence, both bladder and bowel incontinence, saddle anesthesia around the S3 to S5 dermatomes, and absent anal reflex, altered gait. So if they have any of these features, that's a surgical emergency. They need to get a CT MRI and a laminectomy to decompress the cauda equina. Spinal cord injury, again, pre-clin revision, various different classifications of spinal cord injury that you can look through in your own time. If you remember what the bits are of the spinal cord and where they are, you can reason through what things will be preserved, whether it's ipsilateral, contralateral, whether it's DCML, or the others. You can read through that in your own time. Probably not too high yield. Myelitis, again, very, very low yield. This is spinal cord inflammation. Maybe just know that you can get it with multiple sclerosis or other sort of autoimmune conditions. And then I've put some various types on the right. R3 conditions, so don't worry too much about the rest of it. Guillain-Barré syndrome. Probably important not to miss. This is an acute inflammatory demyelinating polyneuropathy. So acute demyelinating condition can be preceded by a viral bacterial infection and is associated with Campylobacter jejuni. This causes a distal symmetrical paresthesia, pain, and areflexia. So it starts from the legs and works its way up. They got sick and now they can't move their legs. Eventually, it rises up, gets to the lungs, and then if you can't breathe, that's very, very bad. So the investigations and management, again, because it's an R3 condition, probably don't worry too much about that. Okay, now on to fits, faints, and funny turns. So this is talking about falls, epilepsy, I felt dizzy, don't know what happened. So in terms of the history, you want to really clearly get a clear idea of, was this syncope or was this an actual seizure? And if it was a seizure, was it provoked or unprovoked? Because that's going to have implications for your management and whether you call it epilepsy and so on. Again, the collateral is key. If the person, fainted and blacked out, they're not going to be able to tell you that much about what happened. So one of the things that you should be asking is, did anyone see the faint or the fall, etc. So one approach you can take is before, during, and after. So before the fall, how were you feeling? Did anything happen? Did you get like any head trauma? Did you have any dizziness, vertigo? Was there any noises, any sort of crying, vocalizations, which I'll talk about in a minute? Then during the episode, what actually happened? Did you sort of black out, white out? Did your legs give way, or etc.? Was there any sort of features of an epileptic seizure, automatisms, rhythmic jerking, muscle stiffness? Were the eyes open or closed? They're mostly open in an epileptic seizure and can be closed in a sort of pseudo seizure. And was there any incontinence, bowel, or bladder? And then importantly, was there any head strike? If they had head strike, they should get a CT brain to rule out head injury, bleeding, and so on. That's during. And then after the episode, did they have any memory of the event? Did they have any features of a post-ictal period? So after a seizure, they may feel confused, tired, weak, generally very blur. If they did, how long did it take for them to recover? Or were they sort of just straight up and running and felt fine afterwards? And were there any residual weaknesses or difficulties? Anything sort of subacute on top of that? So other, of course, general systemic neurosystems review. And when we're thinking about differentiating with syncope, were there any cardiac or respiratory features? Were there any features of anemia? Were there any features of anxiety or depression, and so on? So selected differentials in terms of a faint, most of them, most common, not going to be neuro. Epilepsy is not that, pretty rare. Maybe it was anxiety or hyperventilation. You might expect them to have dyspnea, chest pain, psychosocial history, some kind of trigger stressful event. It might have been vasovagal syncope, so they felt very clammy, sweaty before the episode. They had a bit of a blackout, black curtains coming down. There may have been some twitching, which might be described as a tonic-clonic seizure, but you'd really need to dig into what exactly happened there. Was it a true seizure? And generally, there won't be any memory impairment. Could be postural hypotension if they suddenly stood up, for example, more common in older people or people who've been dehydrated. Red flags, this is where our neuro stuff comes in. Brain tumor, stroke, cardiovascular. Sorry, this is not where most of our neuro stuff comes in, but stroke, AMI, aortic stenosis, of course, a triad of syncope, angina, and dyspnea. Infections like IE, meningitis, and hypoglycemia, which can look like a vasovagal syncope, but can also actually be a cause of a provoked seizure. Okay, so here we get into what we're really worried about, a seizure. A seizure, which I'll talk about in a minute, it can be either provoked or unprovoked. So provoked, think drug overdose, like stimulants, drug withdrawal, like alcohol, in that used car salesman I spoke about earlier, benzo withdrawal, and electrolyte disturbance, so it's hypoglycemia, natremia, calcemia, magnesemia, etc. So if they're not provoked, then there can be unprovoked seizures, and an unprovoked seizure might lead you down the track to a diagnosis of epilepsy, or it may not. Think about sleep disorders and the other masquerades like anxiety, depression, Was it sort of hypo from diabetes? It's drug-induced? Is it anemia? So epilepsy now. One condition, you should know this in detail. So a seizure is a sudden transient neurological overactivity in the central nervous system. And epilepsy is when you have 2 or more unprovoked seizures. So provoked seizure doesn't count. Status epilepticus, if they have a seizure lasting more than 5 minutes, or if they're 2 seizures, but they're basically sort of strung together. In terms of the classification of seizures, you can have either a focal onset or generalized onset. And within focal onset, you can have either aware or impaired awareness, and then that can progress to a secondary generalized seizure. So in terms of the sorts of things that you can look for in just a simple partial or focal onset seizure with preserved awareness, there might just be some well-defined sort of movements. It may be sensory with some unusual sensations, or maybe autonomic with sweating, flushing, gastric discomfort, etc. If there's impaired awareness in a focal onset seizure, that's mostly think about the automatisms that we talked about earlier, the sort of stereotypic movements, lip smacking, etc. In terms of a generalized onset, that's when we're thinking about the sort of big, attention-grabbing seizures. So you can have the neurologists call it an absence seizure, which I think is dumb because it's an English word. Absence seizure or petit mal seizure, common in children. This is where there's sort of just staring, eye blinking for a little bit. There's no awareness that happened. There can be myoclonic with the sporadic contractions, atonic where there's no muscle tone, be tonic where there's muscle rigidity, and the tonic-clonic or grand mal seizure, which is the big one. So they may have an aura or prodrome of irritability hours or days before. And then, so what I'm getting at earlier with the cry, they may have a pre-ictal cry where there's a contraction of vocal muscles and throat muscles just results in that kind of vocalization. This is followed by the tonic phase and then the clonic phase and then a post-ictal phase. In terms of investigations, these are designed to confirm that there's neurological hyperactivity and exclude other causes of a seizure. So Caesar diary, BSLs for hypos, general bloods, consider toxicology, blood alcohol. If they're taking antiepileptic drugs, do a level of them. If there's new onset seizure or new signs without an identified cause, look at a CT MRI brain. Maybe there's something going on, maybe you have a tumor. If there's features of meningism or fever, do an LP, and then do an EEG to look for epileptiform changes. But a normal EEG does not exclude epilepsy. Non-pharmacological management, avoid their triggers, so flashing lights, make sure they take their medication, alcohol, drugs, etc. There can be a lot of stigma around epilepsy, so make sure that you give them good education. And here's the one that's important to remember, the minimum non-driving period for a person with epilepsy. For a commercial driver, it's 10 years. In a private driver, first seizure, it's 6 months. And in a private driver, otherwise, it's 1 year. Of course, don't operate heavy machinery or go out swimming alone, etc. Pharmacological management, basically, if you follow the flow chart, if it's the first time, you can sort of watch and wait. The second time, oh dear, I've clicked the link again. So the first time, if it's generalized or unclear onset, then you use sodium valproate, or in females of childbearing potential without reliable contraception, levetiracetam. If it's focal onset, use carbamazepine, and there are a number of other anti-epileptics that you can think about as well, which have other indications. Important thing to remember is that all anti-epileptic drugs risk causing neural tube defects, and valproate is the worst. So that's why ETG recommends that you can consider the anti-epileptic that no one can pronounce. So look, use contraception, balance the risk of seizure versus NTD, consider changing the therapy, give high-dose folate in the pregnancy. And most of the pregnancies will be unremarkable, but it is a risk to think about. Okay, we're nearing the end. Might have to run slightly over time. I hope that's okay, but hopefully we'll finish soon. There's just some random topics that couldn't fit anywhere else. Glasgow Coma Scale, I'm not sure that it's in the matrix, it may be, but very clinically relevant, and it'll come up soon. Remember that the score is out of 15, 4 for eyes, 5 for verbal, 6 for motor. It's easy to remember. It's easy to forget which the motor ones are when they're really down in the low scale. So just remember, flexion to pain is a better response and extension to pain, right? If someone's sort of attacking you and making painful, you want to curl up and protect yourself, right? You don't want to have at me. So have at me is worse. That's a worse score. Okay. So head injury, obviously, we've sort of talked about the intracranial hemorrhage that we talked about. Other things that can happen with head injury are scalp injury. Remembering back to preclin, because of the anatomy of the scalp, you can get very heavy bleeding. So rule out something more serious and then close with sutures and staples. You have a skull fracture, call the surgeons, or open, simple, compound, etc. If the skull fracture is a basal skull fracture, this can be difficult to detect on imaging. So the things that you really need to be on the lookout for a potential basal skull fracture are hemotympanum, so blood in the middle ear that you can see, periorbital ecchymoses, mastoid bruising, and CSF rhinorrhea or otorrhea. So if there's clear fluid that seems to be coming out of the nose or coming out of the ear, be very concerned about a basal skull fracture. And obviously don't put an NG tube in, and probably don't put anything up the nose of someone with a suspected basal skull fracture, because that leads straight up to the base of the skull. In terms of sort of soft tissue brain injuries, you think of a concussion, which is just a mild traumatic brain injury. No abnormalities on imaging. There was a transient cognitive and altered mental state, but they were fine afterwards. And the GCS, remember from previously, was always at least 13 while they were conscious. Then you can have a contra coup injury, which is basically if someone would bash their head against a wall. The coup injury is the one at the side of the lesion, and then you sort of get a sort of whiplash at the contra coup injury at the opposite side. The contusion is basically a bruise in the brain. There's a little bit of a hemorrhage. It's hyper attenuating on CT because, remember, recently clotted blood, etc., and it can cause a mass effect. Diffuse axonal injury is, the guy who got into a car accident and is very, very unwell. This is the global shearing of white matter, can also involve blood vessels. There is altered mental status, but no space-occupying lesion on CT. On ophthalmoscopy, you may see retinal hemorrhages. And if you see retinal hemorrhages in an unwell baby, consider diffuse axonal injury due to shaken baby. Be worried about that. And investigations, as per trauma, and the management is, again, as per trauma, but obviously if they have a suspected head injury, you must suspect a C-spine injury, so don't remove the collar until a fracture is ruled out. Protect airways, intubate, and maintain BP. If they have cerebral edema, you can use mannitol to reduce the swelling. Constant observation. And if they have low BP after head injury, look for any other injuries that could be causing bleeding, for example, and don't do a lumbar puncture until raised ICP is ruled out. Peripheral neuropathy, again, revised pre-clin, probably reasonably straightforward, but there's a number of different types of peripheral neuropathy that are associated with various things, most commonly with diabetes. The etiology, there are lots and lots and lots. This mnemonic is courtesy of last year's revision lecture. So you can remember drugs, alcohol, vitamin B12, immune conditions, and diabetes. In diabetes, remember that they don't just get the glove and stocking polyneuropathy, they also get autonomic dysfunction and a number of other things that go along with that. And the management, obviously, treat the cause. Okay. Oh, I didn't end up going over time. So if you have any questions, feel free to message me on Facebook, leave them in the chat, or send me an email. Thanks. Okay, let me just go through what the questions were in chat. So one person has asked about, oh goodness me, I've just realized I didn't tell you about the antibiotics for once these sensitivities, cultures and sensitivities come back for bacterial meningitis. So I will update the slides with a slide about what the antibiotics are if you've confirmed that it's, for example, Neisseria meningitis. Epidural is the same as extradural. ROS I just put for review of systems. Okay, if that's all, thanks very much. We can head off to lunch.
Yep, thank you so much, Yingtong. Love your work, love the memes, always very big brain. On that note, we might just head off to lunch, as Yingtong mentioned. We will come back at 2:30, if everyone's all right with that, for some rheumatology content. As yesterday, the link's the same, so you can drop out and join back in. And these slides will also be, the slides are up.